Hi, Dr. Reddy. Thank you for joining us today to discuss Terumo Health Outcomes, ePRISM in the cardiac cath lab. But first, before we start, if you don't mind introducing yourself and your position at Kettering Health.
Sure. Thanks for having me. I'm Dr. Niranjan Reddy. I'm one of the interventional cardiologists at Kettering Health in Dayton, Ohio. Board certified in internal medicine, cardiology, nuclear medicine, and of course, interventional cardiology. And I'm one of the chief of interventional cardiology here at Kettering Health. And I'm a fellow of the American College of Cardiology and fellow of the Society of Coronary Angiography and Interventions.
Great, thank you. It's exciting to have you here to discuss this topic. Before we get into it, I think I'm going to give a general description and an overview of ePRISM for our audience, and then we'll get into some questions and some cases. So ePRISM is a cutting-edge precision medicine software solution. It's designed to enhance and help transform patient care delivery. And it does this by assisting in risk stratification and optimization of patient management. The goal is to enhance healthcare outcomes and operational efficiencies, such as more timely discharge and reduced readmissions. It operates through a seamless integration with the electronic health record, and it leverages a large volume of data, which is actually analyzed in real time. It uses peer-reviewed algorithms, and the software provides predictive analytics, allowing the clinician to make decisions proactively and inform decisions based on risk. For patients undergoing PCI, a personal risk profile is generated as the software assesses specific variables like past medical history, current health status, procedural details, and procedural implications for the patient. It's a prospective approach in contrast to what we've always done is a retrospective approach, and it enables the clinician to decrease the likelihood of potential complications for a specific patient by leveraging a variety of variables that interplay with each other based on an individual patient, and not the retrospective approach that we're used to that basically takes a patient cohort or a patient subset, and we kind of shoehorn that patient into that subset. This enables us to really do risk factor stratification based on the individual patient and based on the interplay of risks as they apply to that patient's risks as they apply to that patient. So with that said, that's really the basic overview. I know that your team has had a significant experience and a positive experience with Terumo Health Outcomes ePRISM software, and I know that it's led to a fairly significant savings overall based on some of the operational efficiencies that are afforded to you by the program. But really today we want to focus on the clinical aspect, which I think we as physicians are very interested in and very excited about, especially with regard to the potential for this software and this solution. And I'd like to ask you a two-part question. One, how has ePRISM itself impacted patient care in your institution? And two, we as physicians get a little squeamish when we hear about the electronic medical record being implicated. We've all initiated learning about electronic medical records. Many of us have transitioned from one to another, and we have all experienced the pain that this can kind of generate. And how could you alleviate that concern or that standoffishness that physicians might have with regard to the memory of the pain of getting on an electronic medical record?
Okay, very good. Let's start with the best word I would like to use. ePRISM is a game changer. So that's the best. Let's start with that.
Good.
It's been for us for sure. It's a game changer. So the benefit of ePRISM is that real-time EHR integration and based on the advanced peer-reviewed algorithms. It has really made us more helpful on the informed decisions while planning our procedures in the cath lab, either be it cardiac caths or interventions. We, in our network, have definitely seen a reduction in the metrics what we looked into, which is especially acute kidney injury and bleeding. And this directly improved the patient outcomes. The platform has the ability to find the actionable items, insights at the point of care, point of care, and we address potential issues before they become serious issues. Like you said it's more proactive than being reactive. So that's one thing. Now, coming into the how did it affect the physicians? I'm the same guy. It's the same way like you, Dr. Martinelli. We started off with paper, then went to one EMR to another EMR, changed different packs and all. So, each time they introduce a technology, first thing we are like, oh, not again. But in this case, I think the best part of the ePRISM was it was user friendly, and it did not, again, I'll say it again, it did not put any extra work on the physicians, because it very easily integrates to your EHR. And in our organization, we have Epic, and it very easily integrated it without any significant difficulties. It pulls the patient's data directly and uses its algorithmical analysis and gives us a very good risk predictions for contrast use or risk of bleeding and all those things. So it has actually not impacted much on the physician work. As such, it's not extra for us.
Great. That's fantastic. It sounds like you've had, good use of the product and success with the product, and not causing any real pain to the physicians getting on the software. How has ePRISM changed your approach to managing patients scheduled for cardiac cath?
So historically, what we did is we saw the patient in the office. We said the patient and the family, we set them up for a heart cath or a intervention. And on the day of the procedure, when they show up, that's when we start looking and saying, okay, you have certain risk factors, you have this. And we took about 4 or 5 metrics, and we assessed and said that, okay, this is your risk of having a procedure or so. It was not a exactly determined number. We used to say, okay, you're high risk or you're low risk, without exactly telling them what's the number or anything like that. We used simple algorithms, just 4 or 5 metrics. We took them and we looked at it. And it was one thing with that was it was cumbersome. It was a little more time taking, and it takes some resources. So that was the original old way. Come ePRISM, it has, because it first of all integrates automatically into your EHR, it does the background work. It really saves time for us, and it tells us a predictive model where exactly we know what's the percentage of a risk of a bleed or a acute kidney injury in this current patient.
For that particular patient.
So for that patient, exactly, like more like a personalized kind of thing.
Right.
And then we tailor it at that time. The other thing we did is not only we waited for the patient to come to the cath lab, what we have done is our pre-admission testing kind of workflow actually assess the patient few days earlier, and they can come up with the risk, and they text us 24, 48 hours before and say that, hey, so-and-so patient coming on so-and-so day has a 12.5 or 18% risk.
Right.
And we would recommend bring them early, do some fluids, and this is what it is. So that really helped us a lot too, doing it before they come to the cath lab. And in the cath lab, of course, using the needed amount of time, more of the time. So I think that was what it is. Now, because it can analyze large volumes of data prospectively and efficiently for all the patients, this has really helped us identify the high-risk patients at the time of diagnosis. Like in the office itself, if you want to use the ePRISM, you can just right away know about that and plan on the day or the before day when the patient comes for pre-hydration. So I think we can now distinguish really the high risk and the low risk for AKI or bleeds more predictably than the crude way we did for several years.
Yeah, and I hear you saying that prior to this, we got out our iPhones and did a couple of calculations on the different risks, AKI, bleeding, and that kind of stuff. And we were really just basically doing maybe you could say a static risk assessment based on historical, cohorts. And here, what you're doing is making a real-time decision in real time based on individual risks. And not only that, you're saying that we used to spend a lot of time and not get anywhere near as precise and comprehensive data that we can now with ePRISM. Would you agree with that statement?
Absolutely. I think that's what it is. I think the technology, what we're using now, literally, I mean, it's all about patient outcomes, as we all
Right.
want to do better. And when you look at that, I think the embedding this kind of technology into the entire care pathway, as I said earlier, starting way in the office, maybe in assessing and risk analysis and predictive analysis, and then coming for the communication, where we communicate to the team, the pre-cath floor or the cath lab, and do that. It was interesting that we did, using the old methods versus now the ePRISM way. There was interesting that there are times when we saw a patient who has had high risk by the old method, calculated as a low risk by the new method, because it looks at more metrics and simple words and algorithmical analysis and all, or the vice versa also. Whom you thought was less might come up with a higher and all those things. So really, ePRISM really helped us optimize our procedures and protocols. Patient safety definitely got better. And of course, that increased our care quality like anything. I think the predefined pathways established by ePRISM was the best. It helped us a lot.
So you're saying less time spent, more precise data. And I understand that you've gotten a significant reduction in your AKIs, near 70% reduction, something like that. Is that true?
Exactly. That's what it is. I think for us, one of the major thing we really showed improvement in our network is the acute kidney injury because of the contrast. Following this protocol, we came almost to 70% reduction, and we have had consecutively 3 to 4 months where we did not have a single patient with acute kidney injury. And we are a high volume lab. We do about 2,500 to 3,000 cases a year. So that was unheard of in our previous ways. So that was really good. Yes, it proved that following a predictive analysis model and doing it well, implementing it well, will show the better patient outcomes.
Great. That's really an impressive finding with the acute kidney injury. Are you seeing, has this improvement in your AKI results translated into daily workflow and overall patient management? And are you personalizing care and experiencing better outcomes overall by enhancing efficiencies?
So for sure, I mean, because of the AKI improvement, we see the outcomes are much better. And with very good planning, we have definitely had a much better workflow, knowing who is the patient who is at high risk, identifying them early, and following a protocol of adequate hydration and cutting down the amount of use of contrast as predicted by ePRISM. In certain patients, it will say, you only need to use 60 ml, and we would be like, really? Because the older method where you use the 3.7 multiplied by the EGFR will take you to 300, and here is 60. I mean, cautiously though, we will be like, initially we were skeptical, but at least we said that, okay, if it's not 60, even you aim for 100, it's better than the 300 from the old way. Right. So I think doing all those things have definitely helped the AKIs and all, and of course saved a lot of contrast too.
That's great. That's great. Above and beyond acute kidney injury, have you seen any other additional clinical benefits to using ePRISM?
So the second thing we also, when we started with the ePRISM, was we wanted to look at our bleeding. Post-PCI bleeding is a major thing in the NCDR data all over the world, and especially in US. So we said we want to look at post-procedural bleeding. And we at Kettering Health are almost about 75% radial first program. So despite that, with so many years of changing into a 75% radial PCI lab, there were still bleeds which were happening, either be cranial bleeds, GI bleeds, of course, and access site bleeds. So we used ePRISM also in that for prediction of a bleed. So it was interesting. I mean, based on the size of the patient or the gender of the patient, the number of anticoagulations on board or antiplatelet agents, it has its own predictive model for this also, and tells you what is the risk of a bleed in this patient who is on your table via a grand approach or a radial approach. So this was very nice that it would give me both ways. And because we are most of the time a radial approach, we would go that. But places where, if I have to say, is there were some physicians who were still doing bypass grafts with femoral approach. And when we used ePRISM, it said that, this patient may have a higher risk. So why don't you try radial? And we started going left radial to get the lima and everything else. So that was again, the word is game changer. It told us, what, be careful with your access and all those things. So I think that was one. And also, as we started looking at the analytics, we also said that how can we get better on the throughput of the lab or something. So that was another thing. So lesser bleeds, more radial approach, patient's same day discharge increased a lot. And as the same day discharge increased, I can give you an example. Let's say you have a case in the morning at 7:30. These patients go home by 11:30. That room can be cleaned and used again by 12:15 for the afternoon patient who is coming for a 1 o'clock procedure. Yes. Which, of course, the hospital loved it, because it's like if you want to use the word, occupancy was great. So I think that helped, and we liked it too, because the outcomes were very good with rapid discharges, same day discharges and all. So I think that was beyond AKI, bleeding and throughput. Both were other two great improvements for us.
Yeah, it sounds like it altered practice, and and put bleeding in the forefront of your mind as far as decision making with regard to procedural access, and then the natural flow from that is increased throughput. So that's great. That's really fantastic. Can you share any specific patient stories? Do you have any specific patient stories that or patient case kind of vignettes that you could share to describe some of these findings that you've had?
So we've been with the ePRISM almost a year now. And of course, we have tons of patients we have used it on, and tons of excellent outcome stories. But I have a couple of them. But before I jump into them, I wanted to show you, if we can, how the ePRISM display comes up on the cath lab when we walk in.
That's a good place to start.
Because we all have this beautiful cath labs with big screen, 65-inch, 85-inch TVs divided into like 4 or 5. And when we walk in, this is what, as you're seeing in the screen, this is what enters as before even it's projected there. So at the time of timeout, we are actually looking into it, and I've actually asked them to include this in the timeout also, saying that, hey, can you please tell us what's the ePRISM calculated risk of anything? So as you see over here, we have 3 things we picked. This is tailored to our institution. We wanted these 3. AKI, which you see on the one on the left, and the middle one is the bleed. And again, as I said earlier, it will tell you the femoral and the radial, what's the risk. In this case, you can see it's like 7% versus 3.8. And of course, the mortality. Again, all these are based on models, predictors, and all predictor analysis, which is being done in the background. We are not feeding too much into it. It goes and pulls it up from your EMR, EHR, and does that. So this actually gives us a very good thing for our clinical team to go ahead and say, hey, how do we do this, and look at it. And I'm going to say this. There are times when we notice this and we say that, okay, we can, if we haven't followed the protocol, which we always do, we can always say that, okay, why don't we move this patient out, give more fluids for 2-3 hours, and bring the patient after the next 2 cases. So we have done that once or twice. And that's actually, I also would think that was very good in doing that. With otherwise, we would have said that, okay, you know what, let's just do it while he's on the table. But taking the time, looking at these numbers and giving that extra time was very good. So with that, I can just jump off into some of the examples. I can do that. Let me start you with my first case. There was a patient who, elderly patient with signs of high AKI risk. For example, he was a 74-year-old female, 5'7", 178 pounds, so little extra BMI, hemoglobin of 12, creatinine 1.2, eGFR calculated as 46. She has multiple comorbidities like COPD, hypertension, and came in with chronic stable angina, which has been changed to an unstable angina. If we go by her old method of doing the method, we would have had, it would have said that it would have been very high. But ePRISM used it and came back and said that despite all these things, she is at low risk for AKI, but high risk for bleeding. So at this point, what we said that is okay, we can no need to bring this patient early to do prehydration, can come on a decent time, but use the radial to decrease the bleeding risk. So we use that. In fact, this was a kind of a staged procedure instead of doing one vessel intervention and bringing them back, because now that we found that the kidney will be able to tolerate it without too much increase in AKI, and we were going radial, we were able to do both the interventions at a very limited amount of dye, and we were able to send her home same day discharge and had a better outcome. So that's one way where we thought there will be someone who will be high risk, but the predictive model said that no, it's not. That's one of the ways where we were able to finish off a 2-vessel intervention radial approach with still minimal amount of dye and had a good outcome. So that was one of the one.
So you combine safety with procedural efficiency and throughput. All
and throughput, yeah, all the three together. Yeah. Exactly, well said.
Great.
The next patient is another one which we always think that they're not that bad. So a diabetic patient, and the labs look great, and we always have been told in our training and practice, diabetes is a high risk. That's true, but when you look at the lab results, sometimes we are under the false comfort and we say that okay, it's not a bad one, let's go ahead and do it. Now this patient, when we put this patient through the ePRISM way of doing things, was a 74-year-old white male. He was a inpatient, which is again not only in outpatients, we are also doing it in inpatient. 6 foot, 319 pounds, hemoglobin 14.1, creatinine 0.83. I can tell you most of them would have said, oh, he's an easy one, not a big deal. And an eGFR of 96. But then when you added the other things like diabetes, a prior MI, chronic lung disease, peripheral arterial disease, heart failure with ejection fractions in the borderline around 50%, and unstable angina coming as an inpatient, we looked at it and this came back and said that he is at risk. And you can see the AKI risk was almost 16.7%. And the amount of contrast it limited to us was about 59. And we were like, whoa, that's not what we came into the room with. But we said, okay, now this is one of our early cases and we were a little skeptical. We were not sure. And we are like, really, come on, we have done these cases before, kind of cowboyish thoughts we had. But we said, okay, you know what, let's follow and listen to this and see what we do. We did it. We were little above, about 88 ml, more, not restricted to that 59 ml. And our creatinine, despite all these things, went up to only 0.33. Now, I want to point out something. With just about 25 to 30 cc more of dye than the predictive model, it went up to 0.33. Imagine if we followed the older way where we did the 3.7 times the eGFR in this patient, especially at 96, it would have been 355 ml. And I can tell you that if we went up to that 300s, this patient would have stayed for AKI for sure. So I think this was another thing where you'll think you're comfortable, you think you know it, but the predictive model based on all the predictors which are proven, right? Peer-reviewed, proven indicators, predictors. Using that algorithm, ePRISM told us, do it with less dye. And I think we learned from that. This was one of the very early ones, which actually gave us that trust and belief, follow the protocol and follow the system. And that, honestly, when we saw this, we pounded it on all the physicians and said that, okay, be serious about this. Even if you don't believe it that it is that low, follow it and limit your die. And I think this was the one. And this, especially having this personalized projection on the screen before the start of the case, was just game changing again. So I think this tells you basically, beyond your conventional risk assessment, using real time data, complex algorithms which have been proven and peer reviewed, using those might actually change your outcomes. And I think doing this, when, like example, I mean, these are the examples I can show and said, basically AKIs, we have significantly decreased by 70% in our network. We are really happy with those outcomes.
That's dramatic. And this is a very striking example, because most of us would not think twice about this specific individual. So, and I would have been as skeptical as you were in looking at that data, and pretty shocked at going a couple of cc's, 20, 30 cc's above and getting a bump in the creatinine. So I think that's striking. And again, we could have spent all day long doing manual risk assessment before the procedure and not come up with that. So I think that's a really striking example. In addition to these striking examples and this important change in practice and improvement in patient care, looking forward, how do you see the role of ePRISM evolving in your facility specifically?
So, as we've been discussing, we started it in the cath lab, looking at AKI, looking at bleeds and throughput, and basically pick those for the quality outcomes. Now, the NCDR, which is our registry for our cath and all, definitely has AKI as one of the metric, has bleeds on the metric and all those things. When we saw this, then we started talking with the Terumo Health Outcomes and all of them and said that, hey, listen, why can't we move it to some other disease patterns, some chronic diseases in cardiology, namely congestive heart failure. Yes. So I think that's our next frontier. As we all know that the readmission rate in congestive heart failure has increased in the recent past all over the country. And that's one of the things every hospital system is working on, because that's a good amount of cost to the hospital. We said, okay, let's see if we can implement the ePRISM way of doing cath lab into ePRISM way of doing heart failure. So that's our next thing. In fact, we are going to start that pretty soon in one of our hospitals, with leadership from physicians and administration who have agreed for that. And I think that's is the next thing we're going to do in heart failure. And I'm pretty sure we will come up with more things with this ePRISM way of predicting, probably bleeds in AFib, bleeds in some other chronic conditions or pulmonary hypertension or something like that. But I think right now, once we are happy in the cath lab, we said heart failure is the next domain we want to do it. So I think that's where we are started. And I think there's a lot of data coming up with doing ePRISM way or standard operation protocol kind of personalized medical management from the ER. In fact, we can start from the ER itself and predict who is the one who is going to be admitted, what's the risk of admission, and go from there, and then tailor the management for that. So heart failure is next.
Yeah, I think that, it's exciting to think about the potential for this software. And I think you hit it on the head with heart failure, because you could take the patient from the ER through the hospitalization and potentially through follow-up using these algorithms that, again, are complex. Heart failure itself is complex. There's a broad spectrum of phenotypes. There's a broad spectrum of clinical, syndromes and treatments. And I think that complexity, kind of lends itself to ePRISM as a solution. So I think that's really exciting, and I'm really looking forward to seeing how we implement this in heart failure. I think that really kind of concludes our discussion. It was a really exhaustive discussion and an interesting, certainly an informative discussion. And I'd like to thank you a lot for your insights and your experience, sharing your experiences with us, with Kettering's experience with ePRISM. You know, it's very exciting, edifying to know that it's made a significant contribution to patient care there, and also helped with all the efficiencies as well. So thank you very much. Thanks for sharing your experience, and we look forward to more excitement as we move this software and this program forward.
So I would say for sure, I would definitely highly recommend it for any program who is interested in patient outcomes. Okay. The integration is smooth. It's not too much work for the physicians. Get the team, Terumo team early, discuss with them. They have very good protocols. They have an excellent team. I mean, they were basically, when we started, they were on the campus for us with full support. We formed teams for that. We did tiger teams. Basically, we identified one physician as a champion for each thing. We picked one interventional cardiologist for AKI, one for throughput, one for bleeds, and we gave them a nurse coordinator, kind of another person, and a team. We created like 4 or 5 members team. We told them to have that, and with the presence of the Terumo professionals, it was amazingly done. And I think earlier involvement by them is the best way. You will feel more comfortable how the transition happens, how it goes. So I'm without doubt, I'm going to say it. If we are truly working on a patient outcome, I think this is the way to go in future. A predictive model analysis kind of things in a real-time setting, peer journal, peer reviewed, peer proved kind of thing. So I would definitely say yes. I think that's one thing Terumo Health has done well is coming up with this kind, and I think it's only going to grow. That's with that. It's, as you said, it's a very nice discussion we had. Thank you for having me. And always, as I said, it's when you feel good that something has done to your network or hospital, you want to spread the message so that another hospital can benefit and better on their patient outcomes. Thank you for
Absolutely, and the patients are the receive the most benefit, which is great.
Yes.
Well, thanks a lot, Dr. Reddy. It was a pleasure.
Thank you very much. I appreciate it.